Good afternoon, everybody. I'm so happy to join you in this esteemed conference and meeting with our mentors and our colleagues from Iraq and, of course, from Middle East and some European countries. To start with this lecture about the adding vision, what we call it, the adding tissue or removing tissue, as our visitor, our doctor before the lecture before, talking about the adding or removing. The adding vision, the future of the corneal disease correction and expanding the surgical armamentarium. From before, when I'm using my machine to do the refractive surgeries, indeed, I'm asking why we are losing this and discarding this enormous amount of tissues from the patients. For example, high degrees of myopia, high degrees of myopic astigmatism, or even the hyperopia in the last 4 or 5 months, and from the VisuMax 800. The modern refractive error correction is no longer limited to improving the uncorrected visual acuity alone. It aims to enhance the overall quality of vision, as you know, the optical performance, long-term ocular health. The integration of the corneal biomechanics, wavefront analysis, and artificial intelligence-driven planning has refined the patient selection, increasing predictability and minimizing complications. Concurrently, the emergence of minimally invasive techniques and lens-based solutions have expanded the treatment options across a wider spectrum of refractive errors and age groups. New advancement in the diagnostic tools, laser platforms, and lens-based technologies have markedly improved the accuracy and safety and patient satisfaction. However, they do not eliminate anatomical, biomechanical, or pathological constraints. Irregular corneas and advanced ectatic disorders, extreme refractive errors, ocular surface diseases, and postoperative regression remains area where current interventions may offer only partial correction or an contraindication altogether. Bridging the gap between the uncorrected cases and the effective clinical management remains a significant challenge in refractive and corneal practice. A proportion of patients continue to experience visual impairment due to untreated refractive errors or corneal diseases. The keratophakia, what I mentioned was the tissue that we are discarding always in our daily practice. The keratophakia surgery is performed as a therapy for high hyperopia, aphakia, or keratoconus, which implants a fresh preserved lenticule from small incision lenticule extraction to the patient corneal surface or stroma. Historically, it started by the 0.2 millimeter thickness and 6 millimeter diameter lens, stromal lens. The lens is implanted in the patient's cornea, which underwent lamellar keratoplasty or keratectomy, and then sutured with the anterior lamellar cap. The implanted lenticule steepens the corneal curvature of the patient and improving the refractive power of the cornea of the hyperopic or extreme hyperopic patients. Therefore, keratophakia is an additive procedure based on stromal tissue that restructure or reshape the recipient corneal surface. The history of keratophakia, as you know, started from 1950s by Paraguay and described the original technique with the anterior lamellar keratectomy was performed in a fresh or preserved cornea whose epithelium and boma membrane and a portion of stroma were eliminated manually to produce a stromal lenticule in a controlled way. Scientists in the 80s from the last century preserved the lenticule in a freezing tissue culture medium or freezing drying environment. To change the shape of the cornea, the recipient cornea also underwent manual anterior lamellar keratectomy, forming the the new shape that is in design. Femtosecond intrastomal lenticule implantation showed increased corneal thickness, reduced spherical equivalent, and improving the uncorrected visual acuity, particularly in patients intolerant for contact lenses. However, the optimal outcome were predominantly observed in mild to moderate keratoconus cases. Mastro Pasco et al. Explored the insertion of a negative meniscus shape, that means the lenticule removed from hyperopic SMILE patients and reinserted in keratoconic patients for the stage 3 and the stage 4 stable keratoconus. Remarkable enhancement in the uncorrected and corrected distance visual acuity were noted, accompanied by a decrease in the anterior mean curvature and anterior Q values. Additionally, both central and mid-peripheral cornea thickness increased significantly post-operatively. Additional potential advantages of the technique are that the cornea with a thin stroma with the thinnest pachymetry below the recommended values for CXL might become treatable after lenticule addition, and the need for the keratoplasty might be delayed or even avoided. I have 4 cases. I will discuss it with you and will show you the cases step by step. The case number 1, 16 years old male patient suffering from poor vision due to extreme hyperopia. The uncorrected distant visual acuity was 6/48. In both eyes, the central cornea thickness was about 480 microns, and the base correct visual acuity was 612. It's very small, the microphthalmic eye with extreme hyperopia. We cannot do refractive surgery, as you know, as a laser on the laser platform because of the limitation of the cornea thickness and the limitation of the spherical correction. This is the pentacam before the surgery, on the presentation, and the other. This is the implantation of the positive lenticule on the stromal pocket for the patient. As you know, see, this is a very quick video for implantation of a positive lenticule in the anterior corneal pocket to reshape the corneal surface and improve the distant uncorrected visual acuity. Even after, this is the OCT for the patient after the surgery. This is day 1 after the surgery, and this is the this is a pentacam after the surgery. We notice the increase in the central cornea thickness with no effect on the anterior chamber depth, and also even there is increase in the basic screen, please. Even there is an increase in the. Just please restructure the data show, please.
Yes.
Yeah. Even there is an increase in the K reading. We notice that the patient central corneal thickness and the AC depth is maintained and even improved in the corneal thickness. Even increase in the K reading, the distant uncorrected visual acuity was satisfying. It's about 612, and the refraction is almost 1.5 in the spherical correction, the final spherical correction, with no need for any glasses for the far. As you know, it's 16 years old, and the accommodative effort is very well, and the patient can cope with the normal life for this refraction. This is the post-operative day 1. As you see here, the cornea is clear, the interface is fine, and everything was, there is no any haze, and there is any obstacles or problem. This is on the left side of the screen, the pre-operative pentacam, and on the right side of the screen, you see the post-operative pentacam and the thickness and the K readings. Case number 2 is a 21 years old female with advanced keratoconus in her left eye. The uncorrected distant visual acuity, as you see here, 6/36, with no any added correction. We cannot satisfy with the glasses. We cannot satisfy with ICL for this patient because of the limited final corrected visual acuity. So what we can do for this patient, and I suggest for her to do implantation of positive lenticule to start with, and after 3 or 4 months And nowadays we are collecting more negative lenticules for such cases. This is the pentacam before the surgery. As you see here, the thinning and the protrusion. And this is the cornea before doing the intervention. And this is the shape of the lenticule we implant in the pocket, and the deeper layer of the cornea is about 165, 170 microns in the deep corneal stroma. This is the cornea after the implantation, and this is a pentacam after implantation. And the patient distant visual acuity was corrected from 636 to 618, which is relatively acceptable for her to plan for the future implantation of Vision ICL. And this is the video of her, of the patient, in the first week after
Zaid,
the surgery.
I think we have to conclude because we don't have time for the two cases, two cases, okay? Okay.
Case number 3, 24 years old man, presented with left eye myopic regression after PRK for three years before, with a central corneal haze, about grade 2 corneal haze, as you see here in the picture. And the refraction was -6, -1, and the base corrected visual acuity is 612. The patient have very narrow AC depth, so we cannot plan for ICL or Vision ICL. The patient cannot plan for clear lens extraction for at least two reasons, with refractive surprise or even attachment because of high myopia to start with. And we suggest for him to implant a negative lenticule, which is, by my informations and with discussion with Dr. Secondo from Germany, he mentioned this is the first time in the world to establish this procedure, and the negative lenticule implantation was done for at least 3 months before, and the correction was very was very encouraging. And this is a negative lenticule implantation, and this is short seconds video. As you see here, implantation in a pocket inside the cornea of the patient, and the centration was done for him. And the post-operative pentacam was improvement in center cornea thickness, and the final visual acuity was, as you see here, 615.
I think we have to conclude, okay?
Yes. The last case is...
can you conclude, please?
Yes, we can conclude. The tissue of the discarded tissue after refractive surgery must be kept, must be respected better than before, because most of the cases we can recycle or reuse in another people within need. Thank you for your listening.
Thank you very much, Dr. Zaid.